Okay, let's start with emergency medicine. So first of all, if the patient is coming to you in the emergency department, you need to know the basic steps, A, B, C, airway assessment, breathing, and circulation. And always remember in CDM, I even gave a question in the group and everybody wrote ABC together. ABC are 3 different answers, okay? If you're in the CDM, you're writing ABC together, then you will get 0 marks, okay? You have to write airway in a step 1 point, breathing separately, and circulation separately. So these are 3 different options. So if the person is coming to us in the emergency department with any road traffic accident, any trauma, first thing we have to do, we have to look for the ABC. If they say that, okay, we have managed the ABC, the person is fine, what are we going to do first? We have to do put the patient on cervical collar. We have to stabilize the spine, put the patient on cervical collar. Then we have to check the patient's airway. If there's anything in the airway, we have to take it out, do any suction. If anything is visible, then we take it out with the laryngoscope. Okay, so depending upon the scenario, we have to proceed. Okay, what they're asking me, and how will we assess the airway of the patient is patent or not? If the patient is able to breathe and speak, if he's talking, it means that, okay, his airway is patent. It's fine. Nothing is obstructing the airway. And if there is obstruction, the patient will present with some agitation. There might be some confusion. There will be cyanosis, respiratory distress. He won't be able to speak. So all these signs, these are the signs of obstruction. And then we have to move on accordingly. After checking the airway, if the patient's airway is he has some respiratory problem, he's not able to breathe properly, or the airways, we see that, okay, he's not patent. After the suction and sweeping of the airway, we have to put him on oxygen, okay? Then if he's conscious, we'll put him on nasopharyngeal airway. If the patient is unconscious, then oropharyngeal airway. Okay, and if after nasopharyngeal or oropharyngeal airway still the patient is not, the airway is not patent, then we have to, he's still cyanosed or confused, we have to move to laryngeal mask airway. Okay, after that, the end is endotracheal intubation. Still not working, okay, go to endotracheal intubation. If you are not able to intubate the patient, or there is some contraindication, like there's some basal skull fracture, then we will move to cricothyroidotomy. So you should just know these steps. Protect the C-spine with what? We have to put the collar. Then sweep and suction, then the airway, LMA, ETT, and cricothyroidotomy. So depending upon which step they are giving you, you have to write the next step. Then after that is the breathing. Same, we have to check whether the patient is breathing properly or not. Is his mental status fine? Is there any agitation, anxiety, chest movements? Is there any stridor? All of these, the airway, breathing, and circulation, remember, we're doing them together. It's not just we're just checking the airway and we're leaving that, is he breathing or not, or we are not checking the circulation. So in the emergency department, all these 3 things are going together simultaneously. So they're working, the things are going one along with the other. If there is any signs of shock, the blood pressure is very down, or patient is going in hypovolemia, we immediately have to pass 2 large bore IV lines, start the patient on fluids. This is the management we have to do. If after even starting the patient on fluids, still he is in hypovolemia, the blood pressure is not being correct, then the next step is we have to arrange blood and go for blood transfusion, depending upon the scenario. Okay. After doing the primary service, then we have this, the shock. They have given us different types of shock. In hemorrhagic shock, there's 1, 2, 3, 4. You should know the percentage. There can be a scenario in which a person is coming to the emergency department with like hypotension, blood pressure 90/50, and there's a blood loss of almost 750 to 1500 cc. The capillary refill is decreased. What is the next step you will do, or what type of shock is he in? So next step is, we have to start him on IV fluids, but they can ask you the degree of shock. Okay, this much amount of blood has been lost. Which degree of shock is he in? So we should know in type 1, there's less than 750 cc, 2, 750 to 1500, 3, 1500 to 2000, and 4, more than 2000 cc. So just remember these blood loss percentage and the volume. Okay. Then GCS. Along with this, after assessing the ABC, we have to assess the GCS of the patient. If the GCS of the patient is less than 8 or less than 8, we have to intubate the patient. Remember that. And it is very important that you know the GCS count. How do we count the GCS? Okay. The maximum GCS a person can have is 15, and the least is 3. So you should know, they can give you a scenario like a lady coming. It's an important CTM question. Okay, I'm just telling you. A lady comes to the emergency department after a road traffic accident or anything. She's unconscious, and she is not able to verbalize. And on further mute yourself. Okay. On further assessment, her eyes to voice, she opens her eyes, she is confused and disoriented, and on assessment of the motor response, she gives no response, or she only localizes to the pain.
Đấy, maksudnya. Yeah.
Just a second, please. Okay, so where was I? Yes, for the GCS, then they will just give you the values. They'll give you like eye opening only to pain. The patient opens the eye. The patient is taking out some unrecognizable sounds and doesn't obey commands on localizes the pain. What is the GCS? Okay, so you should know what is the GCS for all of these. Just go to Google to make yourself more, to practice more on the Google, write GCS calculation questions. Okay, and different questions will pop out. Learn this GCS and just solve those questions. Okay, so it will give you a more easier practice of, okay, then you will be more fluent on it. That this is this, okay, this is the GCS, I can calculate it. So do memorize these. Okay, eye opening is this, spontaneous is 4, then and verbal response, inappropriate words is 3. You should know this in your fingertips. Remember that. They will just give you the findings, and they will ask you to calculate the GCS. And then according to the GCS, they will ask you what is the next step. If the GCS is low, suppose maybe it is less than 8 or it is 8, what is the next step? We have to intubate the patient. Similarly, if the patient is like, we have to check the examine the body of the patient, we have to log roll him. And in always for the trauma patient, we have to do the DRE. Maybe there is some bleeding in the when we do the DRE, maybe the prostate is high riding. So these things, then these are the contraindications to urethral catheterization. Okay, so we have to do DRE. If they say that, okay, we have stabilized the patient, done everything, what is the next examination we will do? We have to do the DRE of the patient. If there's any on examination blood at the urethral meatus, there's a scrotal hematoma, high riding prostate, then we will not put Foley's catheter. Okay, then the next step will be retrograde urethrophy to check that where is the trauma, what is the degree of the trauma. Similarly, for contraindication to NG tube, there is any mid-face trauma or basal skull trauma, we will not put NG tube in the patient. After that, we'll come to the secondary service. survey. We have stabilized the patient. Along with that, now we have checked him, done everything. We have to move to the secondary. What is the first thing we are doing in secondary survey? We are doing the fast examination. Okay, and according to the fast examination, we will know, okay, whether there's any bleeding going on or not. And remember, in fast examination, maybe the patient is the fast examination is fine, but still the patient is going in shock. You have started him on IV fluids. He's not being stabilized. It means there is some retroperitoneal bleed. In retroperitoneal organs, there is some bleeding going on. Okay, because fast will not recognize any retroperitoneal bleeds. So you should know this. Then what is the next step we will do? If the patient is stable on fast examination, okay, we found out that, okay, this is the organ that is damaged. Here the patient is bleeding, patient is unstable. We will, after fast, we will do surgical consultation and laparotomy. If they say that, okay, we did the fast examination, the patient is still unstable, the blood pressure is still dropping, we have started him on IV fluids, fast is normal, what is next? If the patient is unstable, move on to laparotomy. If the patient is stable, then we have to do the CT scan. Okay. Then this ethical consultation, we did it like emergency patient, we don't need any consultation, consent, we just move on. Then if the patient is coming to you, we should know what are the high risk injuries. Okay. If there is a motor vehicle collision resulting in ejection from the vehicle, the person who was driving the vehicle, he ejected out of the vehicle. Okay, then it is a high risk injury. Similarly, if there is a collision with a bike, motorcycle collision, pedestrians versus this vehicle, in some pedestrian walking by and he crashed into a vehicle, then that will be a high risk injury for the pedestrian. Okay, fall from height more than 12 feet. This is for head injury. Fall from height more than 12 feet is for head injury. And if there is a vehicle versus a pedestrian crash, what are we checking? We are checking the Weddell's triad. That is tibia, fibula or femur fracture, truncal injury, and craniofacial injury. These are the things we have to assess. Similarly, for basal skull fracture, what are the signs? There will be battle sign, hemotympanum, raccoon eyes, and CSF rhino. In the Google, write these signs, and you should know the images, what they look like. They can give you a picture of hemotympanum and they can ask you, what is this? Or what fracture could have caused this? Or what can be the cause of this hemotympanum? So just Google these pictures up and look for what they look like. Okay. And the MCQs, they can just give you the picture and ask you what can be the cause of this. Then in the fractures, how do we diagnose? Non-contrast head CT and physical examination. After the physical examination, if still we cannot find anything, we have to move on to the non-contrast head CT scan of the patient. In basal skull fracture, we did what we have. Similarly, then, where is that? If there is any epidural hematoma, okay, what will we have in epidural hematoma? We will have a lucid interval. They will give you a scenario in which they will say a patient is here after trauma, after head injury, RTA, anything. And while bringing the patient in the ambulance, the patient was unconscious, everything was deteriorating, but he wasn't, the GCS was, he was unconscious, was not talking. Now, when he's in the emergency department, after some time, the person is fine and he says that I want to go home. Okay, so it means something is wrong. What is the next step you will do? You will not discharge the patient. The patient is perfectly fine. He wants to go home. He has no headache, no nothing. It means that is the lucid interval. And what is the one investigation we have to do during the lucid interval? We have to take the patient for the CT scan. Okay, because that is a time period just for some time. After we have that time period to immediately take the patient for the CT scan, because after that time period, again, he will deteriorate. Then for concussion is very important. You should know when we have to admit the patient, what is the criteria for admission in concussion, what is the treatment of concussion. Okay, mostly in concussion, they give you a student, like a young child, student, he's a player, soccer player, any other game player, and now while playing the game, he was hit on his head, or he fell down and hurt his head. After that, they will give you that. Now, for some time, he had some amnesia, less than 30 minutes. He was unconscious. He doesn't remember what happened after that, or how the ball hit him. What is the next step? So, and the patient wants to go home. What is the next step? So the next step is that we will first assess him. We will admit the patient. Okay, we will not do any head CT scan. Okay, remember in that, if the loss of consciousness is less than 30 minutes, GCS is more than 13 to 15 initial. Okay, and amnesia is less than 24 hours. We are not doing CT scan in any of these. We will just monitor him, admit him, and even if we are discharging the patient, we will counsel him that at any point, if you deteriorate, you have any vomiting, you have any headache, and there is any unconsciousness, come back in the ED department. If they're giving you a scenario that the patient is with his parents and they want to take him home, then this is what we are going to counsel, these three things. If not, then admit and just monitor the patient for next 24 hours. And then after that, he's fine, but he has a match after one week and he wants to take part in that match. What is the next step? We will tell him that he cannot play. Okay, for at least 1 month, he cannot return to his matches. He has to skip that. We will counsel the patient. Warning signs of severe head injury are GCS less than 8, deteriorating GCS, unequal pupil, and lateralizing signs. Okay, then this is the Canadian CT head rule. You should know that when we have to do the CT scan. Okay, in a high-risk patient, if the GCS is less than 15 after 2 hours of injury, suspected open or depressed skull fracture, any signs of basal skull fracture, vomiting more than 2 episodes, age more than 65. Then for medium risk, amnesia before impact more than 30 minutes, dangerous mechanism. And for minor, what is minor head injury? It is defined as witness loss of consciousness, definite amnesia, or witness disorientation in a patient with GCS score of 13 to 15. Okay, so if anybody is presenting with minor head injury and he, along with that, he has any of this, then we have to do CT head. Otherwise, we will not do CT head. If they just give you a 70-year-old patient, he presented with minor head injury, what is the next step? We have to do CT head because he's not in this criteria. He's already above 65 years. So even if he doesn't fulfill any of this, we have to do. Then after that, what we have is the spinal cord injury. The patient is coming with an injury, stabilize him, put him on neck, the cervical collar, then put him on a spinal board. And for transportation, what will we use? We will use the spine board. We will not take him off from the spine board until the spinal trauma has been ruled out. If they are asking you in a scenario, the patient is coming in the ambulance, in the ED, he's on spinal board. Now we have to take him for the CT scan. What do we do? Put him on some stretcher or take him off the spine board, ask him to walk. Many different options they can give you. So we have to choose. We do not have to take him off the spine board until and unless the spinal cord trauma has been ruled out. Okay. Similarly, while assessing the spine, we will put him in neutral position, palpate the C spine, log roll, then palpate the T spine and L spine, and assess the rectal tone by doing the DRE. So just remember these points. Palpate, first we will palpate the C spine. They can ask you in the CDM, how will you assess or check the spine in a patient of trauma on physical examination. So we will palpate the C-spine, log roll, then palpate the T-spine and L-spine, lumbar spine, and assess the rectal tone. Now, for the similarly, there is the spinal, like the head injury, we have the CT head rule. Now we have the spine rule. Here, any high risk factor for alert, GCS score is 15, and stable trauma patient where C-spine injury is a concern. Any high risk factor that mandates radiography, that is, if the patient is more than or equal to 65 years old, or he has any dangerous mechanism. Now, for the C-spine, the dangerous mechanism is different. This is the dangerous mechanism. What is that? Now, this fall from more than 1 meter. Here, the fall criteria has changed. Axial load to head, for example, like diving. A motor vehicle collision, high speed, rollover or ejection, motorized recreational vehicles, and bicycle collision. If he has any of this dangerous mechanism, or the patient is more than 65 years, or he has any numbness, paresthesia in the extremities, what will we do? We will do the radiography. Okay. If he doesn't have any of this, then what we have to assess is the simple rear end motor vehicle collision. Was the motor vehicle collision from the back? Or is the patient sitting in the emergency department? Was he able to move at any time? Is there any neck pain or absence of midline spine tenderness? If any of this is not present, what we have to do? If there was no motor vehicle collision, he's not sitting at any time. He was sitting at any time. He was moving. All of this was there. Then we do not have to do the radiography. If this is present, he was not able to move, he was not able to sit, there was a motor vehicle collision from the back, there is pain in the neck, then we have to see whether he is able to rotate his neck or not. If he is able to rotate his neck, then no radiography. If he's unable, then we will do radiography. So just the first step, basically they want us to know that if the patient is coming in the trauma, we have to start with ABC, start IV fluids, 2 large bore IV lines. Do we have to do the head CT scan or no? Do we have to monitor the patient? Do we have to consult any surgical consultation? Do we have to do laparotomy? Do we have to do X-ray of the spine? They want us to know these basic steps. Okay. For chest trauma, if there's any airway obstruction, patient will present with signs of any anxiety. There will be cyanosis, hoarseness, unable to breathe, altered mental status. We just immediately intubate the patient. Okay, he's presenting with the signs and we just intubate him. Then for tension pneumothorax or any open pneumothorax, basically it is a clinical diagnosis. But if they're asking you for chest X-ray, we can write chest X-ray. If they're giving you 2 options, then even writing chest X-ray won't be wrong. Okay, but basically it is a clinical diagnosis. What will patient present with? Respiratory distress, tachycardia, distended neck veins, cyanosis. On physical examination, there will be asymmetry of chest wall motion. Trachea will be deviated to the opposite side, absent of the breath sounds on the affected side. So all of these things will be present on physical examination. What is the management? Needle thoracotomy at the second intercostal space and then chest tube placement. So these are the managements which the emergency department physician can do. Okay, remember, so we can do all this. We will do the second intercostal mid-clavicular line needle thoracotomy. We will place the chest tube. For if they say that on the X-ray, you did the chest X-ray and there was some, the patient's, the fast is fine, okay, but on for the patient is presenting with signs of pneumothorax, and on chest X-ray there's some opaque radio opaque present on the chest, like air fluid level is present. So most probably it is hemothorax and the patient is still deteriorating. Then we have to place the chest tube and do thoracotomy. Okay. For flail chest, just the clinical diagnosis, give the patient analgesia, starts on IV fluids and pain control, analgesia for IV fluids, nothing else. Cardiac tamponade, again, clinical diagnosis. And what do we do for it? We do pericardiocentesis. Okay. And how is it diagnosed? Through FAST. In cardiac tamponade, what is the Beck's triad? We have hypotension, distended neck veins, and muffled heart sounds. Remember, they will not specifically write muffled heart sounds. They can write distant heart sound, unclear heart sounds. So any of this, they can just write. Not this word muffled is not specifically won't be there. Okay. If this triad is present in a trauma patient, then most probably it is a we have to do pericardiocentesis. It is cardiac tamponade. Now, if the patient has some pulmonary contusion, what is the complication of flail chest? The complication is pulmonary contusion. Okay. So blunt trauma to the chest, interstitial edema, impairs compliance and gas exchange. How will we diagnose it? With chest X-ray and maintain the ventilation, ABGs, pulse oximetry, do ECG, and chest physiotherapy is the treatment. Similarly, for ruptured diaphragm, there will be on chest X-ray, free air will be present. The intestine will be present in the chest. Okay. We have to do laparotomy, stabilize the patient, surgical consultation for laparotomy. Esophageal injury also diagnosed on chest X-ray, and we have to do repair, stabilize, repair. Aortic tear, they do not survive that much. Similarly for the myocardial injury. Okay, now if there's any penetrating trauma to the neck, we do not remove that any impaled object in the neck or anywhere in the abdomen. They're presenting, the patient has a big log in the abdomen, in the thigh, anything in the neck, we will not remove it in the ED. We will take the patient to the operating room and we will remove it over there, because maybe it is pushing pressure on the arteries and veins, and it has stopped the bleeding. And if we just remove it out, there will be a gush of blood. So we never remove them in the ED. Stabilize the patient, take the patient to the OR. Okay. I've discussed this. We'll do the FAST. If the patient is unstable after FAST, urgent stabilizing the patient, urgent surgical consultation, laparotomy. If the patient on FAST, we did the FAST and still the patient is hemodynamically unstable. Patient is hemodynamically stable. Next step is CT scan. Okay. We didn't find anything in the FAST and patient is stable. We have to do the CT scan. Then for genitourinary tract injuries, we have to do the DRE to assess for any trauma, like high riding prostate, check the external genitalia, any bleeding from the urethra. All of these are contraindications to Foley's catheter. We will not pass Foley's catheter. We will move to, if there's urethral injury, retrograde urethrography. If bladder, then CT scan and ureterogram. If ureter, retrograde ureterogram. Renal, CT scan. Okay. You should know the contraindications, what we have to do. And here, mainly in emergency, we just have to stabilize the patient and then we have to do the consultation. Okay. For orthopedic injuries, this is the, where did it go? Sorry, stuck. Okay. What are, they can give you a scenario where a patient is presenting with a trauma of his femur bone. And now after some time, after one day or within 24 hours, the patient is now presenting with shortness of breath. So the most important thing is fat embolism. It is a very important and common complication, like not very common, but important complication which they can ask. What is the what is the patient presenting with, or what can be the cause of it. So fat embolism, long bone fractures. So fat embolism is very important. Or you stabilize the patient, you put the splint, you did everything. Now, after some time, the patient is presenting with severe pain in the leg. Okay, so depending upon the time, remember, if within few hours the patient is presenting with pain in the leg on dorsiflexion, it is compartment syndrome, and we urgently have to remove the dressing, and we have to do fasciotomy. Okay, along with that, now this is the treatment of compartment syndrome. Within few hours, the patient is present. Now, if the patient is unstabilized, immobilized, okay, and after 2-3 days or after 1 week, the patient is presenting with pain in the leg. So most probably it is DVT. Okay, then we have to treat for DVT. The time period is important in both of these. After, if and always when there is any open fracture, any external contact of the skin with anything, we have to remove that debris, clean the area with saline, and give tetanus prophylaxis depending upon the patient's previous history. Never forget tetanus. Tetanus is very important. Okay, so we're always giving, even in open fractures, there's any abrasion, there's any cut, depending upon the patient's status of tetanus history, we will start the patient on, we will give them a tetanus vaccine or immunoglobulin. What are the 6 P's of compartment syndrome? Pulse discrepancies, pallor, paresthesia, paralysis, pain, and cold, polar. Remember, these 6 P's, they appear very late. So they will just give you that very worse pain the patient is having in the leg, and pain with passive stretch. Okay, don't say that, okay, they didn't give us any of these 6 P's, so it is not compartment syndrome, maybe it is just something else. No, they might just give you just these 2 things, and it will be compartment syndrome. So we just have to do the decompression, remove the constrictor cast, dressing, and emergent fasciotomy. Okay, then if there's any anterior shoulder dislocation. So what are the causes of anterior shoulder dislocation? Mostly any trauma from the back. Okay, anything hitting the shoulder from the back, it will cause anterior shoulder dislocation. And what are the complications? Axillary nerve damage and musculocutaneous nerve damage. We will stabilize it, immobilize, and after that, just follow up. Okay. Colles fracture. It is a patient coming to you with a fall on an outstretched hand, maybe an old lady. She fell on her hand, and now she's having pain in the arm. On the X-ray, what will we find? We will find a fracture of the distal radius. Okay, what we do? Reduce, immobilize with splint, and follow up with orthopedics. Scaphoid fracture. The complication is very important. Risk of avascular necrosis of the scaphoid bone. Okay, and what will they give you? Just somebody, male, female, they came, and now with a history of fall, on examination, everything is fine. On X-ray even, it was negative. Okay, then most probably like physical examination, the hand is fine, or there'll be just 1 point. They might not even give you tenderness in the snuff box, just pain in the scaphoid tubercle, mild pain is present. Okay, any one of these features, they will just give you any one of these features. X-ray is negative. What is the next step? We have to put the thumb spica splint. Okay, if we are suspecting scaphoid fracture, just put thumb spica splint, and after 2 weeks, we have to do the, if it is negative, then we will repeat it after 1 week. If it is positive, then we repeat it after 2 weeks. But mostly they will give you it is negative. They won't give you any findings, and they will ask you what is the next. So we put the patient on thumb spica split, ask the patient on follow-up, repeat the X-ray in 1 week, and then after that, they will ask you what is the complication. What is the one complication the patient can get? Okay, so the complication is avascular necrosis of the scaphoid bone. Then we should know the Ottawa knee rule and ankle and foot rule. So what is the knee rule? If somebody is coming with a knee injury, we should know when we have to do X-ray of the knee, any history of injury to the foot, when we have to do any X-ray of the foot or the ankle. Okay, remember, they do not want any unnecessary investigations, even in the emergency department. That is why they have created these rules. If age is above 55 years or older, tenderness at the head of the fibula, isolated tenderness of the patella, inability to flex or inability to bear weight at any time in the emergency department or at the time of the injury. If any one of this is present, we will go for the X-ray. If none of this is present, we will not do any X-ray. Even if the patient is saying, I'm in pain, I'm this and that, no, we will not do X-ray. For the ankle, what is it? Pain at the median and lateral malleolus, okay, and unable to bear weight. So if there's any pain or tenderness at the medial and lateral malleolus and the patient is unable to bear weight, then we have to do an X-ray of the ankle. Similarly, for X-ray of the foot, if there is pain at the base of the fifth metatarsal, pain at the navicular bone, or unable to bear weight, any one of this they are giving you in the scenario, we have to do the X-ray. If they're giving you nothing, then we do not do X-ray. For wound management, patient is coming with any, I've told you, any abrasion, any cut, any bite, we have to do the tetanus prophylaxis. First, we will clean the area of the bruise with normal saline, okay? Remove any foreign body, and then depending upon the patient's history, what we will do, we will give him tetanus prophylaxis. And what is the history? If it is a clean wound, okay, and you should know what is the difference between a clean wound and a dirty wound. In dirty wound, what do we have? Any wound contaminated with dirt, feces, soil, saliva, puncture wounds, aversions, or wound resulting from missiles, crushing, burns, and frostbite. In all these scenarios, these are wounds. Even frostbite, burns, we will give tetanus. If a person is gardening in the garden and they may be stepped on a nail, okay, which was rusty or even not rusty, then that is a dirty wound. Patient working in the garden and cut himself with some wire in the garden, that all of these are dirty wounds, okay? So if he has just clean wound working in the kitchen or somewhere else, he just has a clean wound, what will we do? Does the patient have any history of tetanus vaccination or no? If he has a complete history, he was vaccinated, given 3 full doses, then we do not give them any vaccination, okay? But if the history of complete vaccination is more than 10 years, it has been 10 years since he got vaccinated, then we will give the patient the vaccine for Tdap. Similarly, for dirty wound, if the patient has no history, then we will give both Tdap and immunoglobulin, okay? But if the history of the vaccination is less than 5 years, okay, within 5 years, he got vaccinated, we will not give them anything. But if it has been more than 5 years, the person got vaccinated for tetanus, then what will we do? We will give the person the vaccination, okay? For dirty wound, it is 5 years the time period, and for clean wound, it is 10 years. Then abdominal pain. Similarly, we should know the DTs of abdominal pain. Okay, what are the different DTs? What can the person present with? After taking the complete history, physical examination, doing the physical examination, we have to move on to the investigations. Depending upon the patient, what they are presenting with, we will do the investigations. Okay, if there is any sign of peritonitis, rigid abdomen, and pain in the abdomen, then what are we doing? We have to do the X-ray, okay? Chest X-ray, look for pneumoperitoneum, free air in the diaphragm. If any gynecological problem, We have discussed this. We have to do ultrasound. Any other thing we are suspecting, any appendicitis, any patient is presenting with pain in the flank area, any history of nephrolithiasis, then except for excluding the children and the females, we do CT scan. Okay, but in children and female, we do the ultrasound. If the patient is presenting with any foreign body or any obstruction, what do? We do abdominal X-ray. What is the management? This is the management we should know. With presenting with abdominal pain, what we have to do? NPO, IV, NG tube, analgesics, antibiotics, antiemetics, depending if the patient is presenting with nausea, vomiting, we have to give antiemetics. Okay, and then surgical consultation. This is the only for an emergency department. Patient is presenting with abdominal pain. For example, the patient is presenting with a small bowel obstruction. What will we do? We'll do NPO, keep the patient NPO, pass IV lines, put NG tube for decompression, give the patient analgesics, and that's it. That is our job is done. Okay. If the patient is presenting with pain in the epigastrium, and we are suspecting with nausea, vomiting, he's an alcoholic, then we are suspecting pancreatitis. Similarly, for pancreatitis, this is the treatment we have to learn. We should know. Okay, that's it. Our job is still here. This is the management of emergency department abdominal pain. We just have to stabilize the patient. Where if the patient is presenting with signs of peritonitis, any signs, or he had a history of peptic ulcer, and now he's presenting with signs of peritonitis, and what will we do? Just stabilize the patient, keep the patient NPO, IV line, NG tube pass, analgesics, and after that, surgical consultation. We will not perform the laparotomy. We are not doing anything. We will just write surgical consultation for laparotomy. Okay. Our job is to stabilize the patient. For pelvic pain, any female is presenting in the emergency department with any pelvic pain, any abdominal pain, first thing we have to do is beta HCG, okay, to rule out any pregnancy. Similarly, if there is any pelvic or we do pelvic or abdominal ultrasound for adnexa, thickness of the endometrium, pregnancy, free fluid, depending upon the scenario. If there's ovarian torsion, what we do have to do? We have to do a Doppler ultrasound. Okay. Now, if the patient is, if there was any history of ovarian cyst, and now they're presenting with pain, and we see on the ultrasound that, okay, the cyst has been ruptured, but the patient is stable, like hemodynamically, she's fine. If the patient is hemodynamically fine, we'll just put her on follow-up. Okay, nothing has to be done. Give her something for the pain and follow up the patient. But if she is unstable, then we have to do gynecological consultation. She might require, she requires a surgery. If the patient is presenting with any signs of any testicular, a young boy is coming with severe pain in his testicles, and we are suspecting there's a testicle torsion. So after the physical examination, we will not manually just reduce the torsion in the ED. No, we have to do it in the OR. Okay. It's the GCS we read. Okay. Also, if the patient is presenting with any altered level of consciousness without any trauma, okay, just the patient is coming in the emergency department and they're bringing it to you that the patient has an altered level of consciousness, maybe the patient is having seizures. What is our approach? This is our approach, the don'ts criteria, okay. Start the patient on dextrose, start the patient on naloxone, start him on thiamine, and yes, and oxygen. So we should know any patient coming to the emergency department with any altered level of consciousness, maybe he's alcoholic, maybe the patient has some history of seizures, maybe the patient has some hypoglycemic, we don't know. So if they're not giving you anything in the scenario, this is the 4 things we have to do. Start the patient on oxygen, start on the dextrose 50%, put him on thiamine and oxygen. Okay, naloxone. And what are we doing? The first thing we are doing, we have to, after the physical examination, proper history, we have to do the blood glucose level. And the best thing to assess the blood glucose level is the capillary blood glucose level. You also call it the Acute check or the finger prick test. Then do the electrolytes, creatinine, BUN, LFT, CBCs, and the toxicology screen. If the patient is presenting with chest pain, the 4 tests we have to do: patient presenting in the emergency department with chest pain, chest X-ray, cardiac biomarkers, ECG, and D-dimer. Okay, the 4 tests. If they are just giving you, a person is presenting with severe pain in the chest, what is the next step we have to do? We have to do these 4 tests. Now, depending upon the history, if they are giving you the history that, okay, the person has a history of any angina or previous MI, any atherosclerotic disease, and in the history they are giving you any features also, then depending on the features, we might not write D-dimer. Okay, we just write chest X-ray, cardiac biomarkers, and ECG. Then the management. So what is the management if there's acute coronary syndrome? There's new or worsening pattern of retrosternal squeezing or pressure pain, radiation to arm or neck, dyspnea, worsened by exercise, relieved by rest, nausea, vomiting, and syncope. So on the ECG, if the patient if the patient's ECG is fine and the patient cardiac biomarkers are fine, so most probably the patient has unstable angina. If the patient's ECG is showing ST elevation, it is abnormal, cardiac biomarkers are also abnormal, then the patient has MI, okay, ST elevation MI. Then if the patient ECG is fine, but now only the cardiac biomarkers are elevated. So what is that? That is non-ST elevation MI. So depending upon what the findings are, we will proceed. And what is the management in the ED? First, we'll do ABC. We will give the patient aspirin, and after aspirin, we have to give anticoagulants. Okay, after anticoagulant, emergent cardiology consultation. If the patient has MI, what we will do, depending upon the time, if less than 90 minutes, 120 minutes, we will proceed to PCI. If any contraindication or PCI is not present, we will move to thrombolytics. If the patient has unstable angina or non-ST elevation MI, then what do we have to do? We have to do angiography. Okay. Similarly, for pulmonary embolism, patient, she traveled last week, and for a few days, she has a history of pain in the leg, and now she's presenting with dyspnea, not able to breathe properly, chest pain, pleuritic chest pain. What are we suspecting? We are suspecting pulmonary embolism. What we have to do? We have to do D-dimer, and then, then we have to do CT angiography. Okay. If there's any contraindication, like the patient has any kidney disease, she is a pregnant lady, or the patient has any history of any allergy to the dye, then we will do ventilation perfusion scan. Otherwise, we have to do CT pulmonary angiography. For DVT in the leg, if they're also giving you for the pain in the leg, then we have to do the Doppler ultrasound. What will we do? We will start the patient on ABCs, and we will start them on anticoagulation. Low molecular weight heparin, switching to warfarin, and then later on to DUAC. Okay, direct acting oral anticoagulants. Okay. Then we have acute pericarditis. In acute pericarditis, the patient had some viral, well, most probably they'll give you a scenario. The patient had a viral infection 1 week or 2 weeks ago, and now is presenting with pleuritic chest pain in the chest. Okay, and everything is fine. But on the ECG, There will be reverse changes, reciprocal, PR elevation and ST depression in AVR and V1 lead, and diffuse ST elevation. Otherwise, cardiac biomarkers, everything will be fine. There will be just a history of viral infection. So most probably it is acute pericarditis. And for that, what do we do? For acute pericarditis, we give the patient NSAIDs. Okay, high dose NSAIDs are given. And we will counsel the patient. If the pain gets worse, come back to the emergency department. And for recurrent pericarditis, we will give him colchicine. It can even be some uremic pericarditis. The patient might have a history of any kidney disease, and they are on dialysis and now they are presenting with this chest pain. So the management will be the same, and the cause will be uremic pericarditis. For pneumothorax, any trauma to the chest or thin, lean person just playing and now immediately comes to your emergency department with shortness of breath, decreased breath sounds, dyspnea, hypotension. On physical examination, we see there are findings of pneumothorax. So what we will do? Similarly, same needle thoracotomy. Aortic dissection, it is sudden severe tearing retrosternal or mid-scapular pain. The patient will give you a history of any atherosclerotic disease, and now all of a sudden they have pain, tearing pain radiating towards the back, towards the shoulder. And they will be on examination, there will be difference of the BPs in the upper extremities. What we have to do? Reduce the blood pressure and heart rate, and surgical consultation we are doing. Okay. Cardiac tamponade, we did it, Beckstride, clinical diagnosis, pericardiosynthesis. In GERD, they can, all of these are what? The DDs of chest pain. Remember that also, okay? So if they're asking you, the patient is presenting with chest pain, what are the DDs? Just, you can write all of these in the DDs. Then the patient will have a history of metallic taste in the mouth, history of regurgitation, history of taking PPIs, maybe on PPIs, may not be on PPIs, depending upon the scenario. And now they have chest pain. The chest pain is constant, or the chest pain occurs after eating food. So it is good. Stabilize the patient and put them on a trial of PPIs. If they are smoker, if they take a lot of caffeine, alcohol, just counsel them to stop taking it and counsel them on lifestyle modifications. Herpes zoster, there will be a pain and maculopapular rash. Okay, what is it? Just a clinical diagnosis. ABCs, antiviral, analgesia. Musculoskeletal pain, the differentiating point for musculoskeletal pain will be that the pain will be on palpation. There will be pain when we palpate the patient on that specific area. They will present with pain with movement on palpation. So we will do X-ray just to rule out any other underlying cause. Otherwise, it is clinical diagnosis. Start the patient on ABCs, do the ABC and start on NSAIDs. Anxiety, sudden onset of chest pain with a history of anxiety, sweating, history of depersonalization, derealization, maybe some environmental factors will be there. What we do? Just diagnosis of exclusion. Everything will be fine. So the patient has anxiety. And we'll just provide them with psychiatric consultation and some breathing techniques, cognitive behavior therapy after doing the ABCs. Next, we have headache. Okay. For headache, there can be different causes of the headache. Okay, most common is migraine. Patient with a history of migraine is now presenting with acute pain, very severe pain in the emergency department. What we have to do? This. Okay, severe pain in the emergency department, start the patient on bolus normal saline, metoclopramide, diphenhydramine, ketorolac, or dexamethasone. This is the treatment of severe migraine in the emergency department. Otherwise, if the patient is in the family physician, they're coming to pain, then we have to start them on prophylactic treatment like NSAIDs, counsel them, start them on TCAs. That is the prophylactic treatment. Unilateral throbbing aggravated by activity, moderate severe intensity, nausea, vomiting, photophobia, phonophobia. Okay, what will be the neurological symptoms? They can be any paresthesia of any part of the body, any numbness that can last for days, and then after some time it will get better. So those are the neurological symptoms. Then if the patient will present with some tension headache, it will be a history of band-like headache all over the head. And now they have some history of some recent stress. Maybe a businessman is coming to you that I have some problems in my business, and for the last 1 week, I have pain all over my head. What do we have to do? We just have to tell him about, give him NSAIDs and stress relieving techniques. Okay, we will connect him with some social services, tell him about some how to relieve his stress, improve his sleep, all these things. Sudden onset of worse pain, that is subarachnoid hemorrhage. Okay, and for subarachnoid hemorrhage, the patient will remember the exact point or timing at which the headache started. Okay, and in this, they will give you the history of worst headache of life. They never had such headache ever before. They will have some meningeal signs, Kernick sign, Brudzinski sign, nausea, vomiting, pain with exertion. So this, what we have to do? We have to do the CT scan. If the CT scan is normal, if we're still suspecting subarachnoid hemorrhage, move on to lumbar puncture after 6 hours and urgent neurological consultation. For subarachnoid hemorrhage, what is our management? CT scan and neurological consultation. If the patient has increased intracranial pressure, they will mostly present with a headache in the morning, early morning headache, headache with coughing, headache with bending down. These are going to be the symptoms. After the physical examination, on the physical examination, we will find some neurological deficits. We will see papilledema. We have to do CT scan and neurology consultation. Meningitis, a child coming or an elderly coming with nausea, vomiting, Kernick, Brudzinski sign is positive, high-grade fever, maybe there is a rash on the body. So what are we suspecting? We are suspecting meningitis. In meningitis, the treatment is start the patient stat on IV antibiotics. Okay, we will not wait for any blood culture results. We will not wait for any lumbar puncture. Start the patient on antibiotics. And along with that, what are we doing? We are sending the blood for culture and sensitivity report. We are we will also start the patient on steroids, antibiotics and steroids. And then what will we do after excluding any signs of increased intracranial pressure? That we can do by any papilledema, checking by on fundoscopy, okay, or doing the head CT scan. After that, we will do the lumbar puncture. So we won't just immediately jump to the lumbar puncture. And if they give you all the person coming to you with all the signs and symptoms of meningitis, what is the next step they're asking you? The next step is we have to start the patient on IV antibiotic, broad spectrum empiric antibiotic. This is what we have to write, okay? If they ask you the name, then ceftriaxone, vancomycin, and ampicillin. Similarly, for giant cell arteritis, mostly females above 60 years of age, and they will present with signs of like difficulty in chewing, difficulty in combing the hair, headache. So if we are suspecting giant cell arteritis, immediately we have to start the patient on high dose steroids. And why do we have to start? Because to prevent blindness. Even we are suspecting giant cell arteritis, start the patient on high dose steroids. Along with this, the giant cell arteritis is associated with polymyalgia rheumatica. Okay, both of these are associated with each other. So the person can give you history of headache, history of stiffness in the shoulder, in the back muscles.
Can I call you back? I'm in lecture to see.
What do? We will start the patient on high dose steroids. And what is the investigations we have to do? First, we have to do ESR CRP and the gold standard. If they are asking you just one gold standard, or like the diagnostic investigation, then we have to write temporal artery biopsy. Okay, if they are asking you that we started the patient on steroids, what are the lab investigations we are doing? Then we have to write ESR CRP. Okay, not immediately, we won't jump to the temporal artery biopsy. Depending upon what they're asking you, our treatment will investigation changes. One diagnostic, then that is temporal artery biopsy. If what is the next investigation after starting the patient on steroids? ESR CRP. This is the joint pain. It's the same like we did in family medicine. Okay, just take proper history, do the investigations, do the physical examination. Depending upon the examinations, then we have to do the investigations and treat the patient. For the back pain also, it is the same. Just always remember, for the back pain, if the patient is presenting, we always have to rule out quadra equina. Okay. So, and what do we do for quadra equina? We have to give dexamethasone and urgent neurological consultation for decompression. Quadra equina is very important. And if the patient is presenting with back pain, we have to ask the red flag questions. We have to ask the quadra equina questions. Then for seizures, what do we have? The patient is presenting for the seizure, first time, elderly person, just do CT scan. Okay, then we have to do take proper history and do proper investigations depending upon what type of seizure it is. Maybe it is just the patient just has hypoglycemia and they are having seizures. Do they have a history of seizure? Okay, do they have any aura with seizure or no? Do they have any autonomic symptoms with the seizure or no? Depending upon the history, physical examination, we will proceed. If the patient is on investigation, they're asking you, patient is presenting with seizures, and what is the next investigation? We have to do blood glucose, capillary blood glucose. Then, and for the treatment, we have to protect the airways. We have to put the patient on left lateral decubitus position. We have to start the patient on ECG, do the vitals, check the oximetry. Then we will start give them benzodiazepines. In benzodiazepines, what do we give? Give them lorazepam IV or midazolam IM. Okay, fluid IV lines and IV dextrose. Maybe the patient is hypoglycemic, so just giving the dextrose will fix them. Even after doing this, the patient is not getting better, then what will we do? We will give them phenytoin. Okay, after giving phenytoin 2 times, the patient is not getting better. Then what we have to do, repeating the phenytoin twice, we have to prepare him for ICU. And what will we do? We will start them on phenobarbital or midazolam IV and shift the patient to the ICU. Okay. And if the patient has a history of seizures, the patient is epileptic, always counsel them, tell the Ministry of Transportation, tell the patient they cannot drive, then counsel the patient about the lifestyle modification, like they cannot swim alone, do not bath alone. If taking showers, don't lock the washroom. Avoid jobs like high machine which have machinery around them. Avoid any hiking. All these things we have to counsel the patient about. Shortness of breath, the same. It can be chest pain or shortness of breath. They have the same DTs and the same investigations we have to do. Okay. And syncope until and unless it is ruled out, most probably it is cardiogenic. Okay, so if there's no history, the patient is just presenting with syncope, mostly elderly patient, syncope, history of dizziness, so mostly it is some cardiogenic cause. Okay. What will we do? We will check the blood pressure, heart rate on physical examination, do a complete history, complete neurological examination, do the ECG of the patient, bedside glucose, CBC, electrolytes, burn creatinine, troponins, toxicology screen, and ABC IV oxygen monitor. If there's cardiogenic cause, then just admit the patient and proper monitoring. Sexual assault, our job as a emergency department physician is just to treat the medical issues. Okay, so we will do the ABCs. If there is any injuries, we will treat them. If then we have to report it. And along with that, if there any picture has to be taken, remember, we do not take it from our personal camera. We have to do it from the camera of the hospital. Along with that, we will take all the evidence in the sexual assault kit if the sexual assault has been occurred less than 72 hours. If the patient is less than 16 years old, we have to report it. Even if they are consenting, not consenting, we have to report it. But more than 16 years or more than that, then we require the consent of the patient. If the patient gives the consent, then we report it. If they do not give the consent, we do not report it. Along with that, what will we provide them with? We will provide them with psychological support, with other social services. After doing the complete examination, what are the investigations we have to do? We have to do VDRL for syphilis, we have to do beta ICG, we have to do blood for ABO grouping type and hepatitis and HIV. Then we will start the patient on tetanus prophylaxis, give the patient emergency contraception, assume the patient has a gonorrhea and chlamydia, give the patient treatment for them, give the patient treatment for post-exposure hepatitis B and HIV. Okay, we are doing the test also, but along with that, what are we starting? We are starting the patient on all these things. Yes, and follow up within 24 hours for repeat pregnancy and STI testing. If there's any intimate partner violence, what will they present? They will present with a history of some vague pains or vague issues somewhere here and there. We just have to counsel the patient. We can tell them it's her choice if she wants to report it or doesn't want to report it. Depending on the patient's history, if they want to report it, fine, we will report it. Always ask about, if it's a female, always ask about children also. And remember, intimate partner violence can be there in males also. It is not necessary that they give you a scenario of a female coming with a vague history and vague pains here and there. It can be a male also. They are also a victim of it. Talk about all the emergency and the safety plan we discussed in the family medicine. Parents are bringing in a child with shortness of breath. First time he ate something, like first time he ate fish or peanuts, nuts, and now immediately he's not able to breathe. He has some rashes all over the body. What we have to do? It is an anaphylactic reaction. We have to give the patient IM epinephrine. Okay, but if the patient is just presenting with no respiratory compromise, even if elderly is coming, a female or a male, 30 years old, they were eating outside in a restaurant, all of a sudden, after some time, this developed some rashes somewhere in the body and it's urticaria, then just give them diphenhydramine, antihistamine. If there are no signs of respiratory distress, we do not give epinephrine. If there are signs of respiratory compromise, then we give epinephrine IM. And what do? We admit the patient and we counsel the patient that there can be, after giving the epinephrine, if the patient is perfectly fine, we counsel the patient that there can be another reaction within next 24 hours, and which is called biphasic reaction. So keep an eye on that. Okay. And in anaphylaxis, always there are two systems involved. The patient can present with respiratory compromise along with hypotension or just abdominal pain. It's not necessary that there's a respiratory compromise and along with that there's urticaria, along with that there's some itchiness all over the body, some rash. No, maybe there's just respiratory compromise and maybe just along with that there's some abdominal pain, just nausea, vomiting, or there's just some urticaria all over the body and the patient has some abdominal pain. So these are anaphylactic or allergic reaction. So when 2 or more body systems are involved, it is most likely to be an allergic reaction. If there is respiratory compromise, epinephrine, start the patient. After that, we have to repeat the epinephrine at least 3 times. Okay. If not working, then we intubate and move on to the next step. Epinephrine, antihistamine, salbutamol can also be given. Severe reaction, airway, definitive airway management due to airway edema, epinephrine, then antihistamine, same glucocorticoids, and if the patient is on beta blocker, then he will not respond to epinephrine. Okay, we have to first give them glucagon and then epinephrine. And always on discharging the patient, give them the EpiPen, counsel them, tell them how to use it, and ask them to follow up with their family physician. Asthma, patient presenting in the emergency department with history of long-term asthma. His FEV1 is more than 80% and has difficulty in breathing, maybe talking in phrases, shortness of breath. What is the next step? What are the next 3 steps or 4 steps we are going to do? We're going to start the patient on oxygen, start them on Ventolin, start them on anticholinergics, start them on steroids. Next question, even starting the patient on these things, his oxygen level is not increasing. What do? Intubate the patient, because you already did all this. Now the oxygen level is not getting better. What we have to do? We have to intubate the patient. Or the patient, they might just give you the patient has some silent chest, the oxygen level is very low, the PCO2 is more than 45, then we just intubate directly. And along with intubation, we will start the patient on short-acting beta agonists, anticholinergics, and IV steroids. Methylprednisolone is given IV, okay? These are steroids. Methylprednisolone is always given IV and prednisone is given orally. This is the difference between the two. So remember, if there's what are different types of asthma? Respiratory arrest, imminent. The patient will present with exhausted, confused, diaphoretic, cyanotic, silent chest, ineffective respiratory effort, decreased heart rate, oxygen saturation less than 90%. If they give you any sign of silent chest, okay, cyanotic, the patient is turning blue, has silent chest, then immediately intubate. Do not do these things. Just intubate first, then do all this. Okay. If severe asthma, these are the signs and symptoms. What are the elements of what well-controlled asthma? These are the elements. Okay. Daytime symptoms less than 4 times per week, nocturnal symptoms less than 1 time, no limitation, inactivity, no absence from work or school, rescue inhaler use. What is rescue inhaler? It is Ventolin. Less than 4 times per week, FEV1 less than 90%, and PEF less than 10 to 15%. Mild and infrequent exacerbation. After you have intubated the patient, okay, now the next question might be, what are the risk factors for the patient's condition? These are not the risk factors, okay? These are the risk factors. Risk factors for recurrency are frequent ED visits, frequent hospitalization, recent steroid use, recent exacerbation, poor medication compliance, prolonged use of high-dose beta agonist. You should know these risk factors. It can be a CDM question. You have stabilized the patient. Next question is, what were the risk factors for the patient's presentation? So these are the risk factors. And whenever discharging the patient, give the patient inhaled corticosteroids. Okay. Then the cardiac, these ones you need to see the ECG. So if I do cardiology with you, we will discuss them with the ECGs. Okay. Then there's acute exacerbation of COPD. Similarly, the patient will have a history of COPD, now presenting with acute worsening of symptoms. What are the three cardinal signs? If the patient has increased dyspnea, increased coughing, and sputum, increased amount or prurulence, then these are the three signs of exacerbation of COPD. What can be the causes? It can be patient might have some history of viral infection, maybe there was some pneumonia, maybe there was some flu-like symptoms, patient have congestive heart failure along with COPD. So all of these are the triggers for exacerbation. What will we do after doing the investigation, CBC, chest X-ray, ECG, cardiac biomarkers to exclude any cardiac cause? We will put the patient on oxygen. Start them on bronchodilators, beta-2 agonists, anticholinergics, prednisone. We are giving orally or IV methylprednisolone. Okay, start patient on antibiotics. And what do we do? If still not getting better, we have to start on CPAP or BiPAP. Okay. And when are we starting the patient on antibiotics? If they are giving us any two of the symptoms, the patient has increased sputum production, patient has dyspnea, and the patient has increased cough. So any two of these are present, we will start the patient on antibiotic along with this. So mostly they will give you all three of these symptoms or two of these symptoms. So we have to write antibiotics. Then heart failure. What is the most important cause of exacerbation of heart failure? That is, patient forgot to take his medications. They are not compliant with their medications. They are not taking them properly. So that is the most important cause of the exacerbation of heart failure. What will the patient present with? In left-sided heart failure, they have dyspnea, shortness of breath, orthopnea, nocturnal dyspnea, nocturia, fatigue, altered mental status, pre-syncope, angina, hypoxia. Similarly, in right-sided heart failure, they will have edema, elevated JVP, positive abdominojugular test, and ascites. Okay, so mainly in right-sided, there is more edema and ascites. And in left-sided, they will present with shortness of breath and dyspnea. This is the main differentiating feature between the two. Treatment, this is the treatment, LMNOP. Okay. Make the patient in the sitting position, start on oxygen, give the patient morphine, give the patient nitrates, start on nitrates, and Lasix, furosemide. So this is the treatment of congestive heart failure in emergency department. Just remember this LMNOP and you'll do the question. One, if they're asking you one test we have to do to differentiate it, then we have to do BNP. This will differentiate us whether it is any COPD, any other cause, or it is the congestive heart failure is the cause. So BNP we have to do. And then, of course, cardiology consultation in the end. Thromboembolism, same. DVT, we already covered it. Empalpable DVT, the patient will present to you maybe a female, she's on oral contraceptives, or a pregnant lady might come to you, maybe a history of any coagulopathy after long-term immobilization. Old patient might present to you with pain in the legs, swelling, or patient had some trauma and now they're immobilized for a long time. Elderly patient in the nursing home, now they are bringing him in because of pain in the leg. So all of these can be the risk factors. They can present with any one of these scenarios. Okay, so what do we have to do? We have to do D-dimer, we have to do Doppler ultrasound, the diagnostic Doppler ultrasound, and after that we'll start the patient on these DOACs, direct oral anticoagulants. If the patient is pregnant or the patient wants to get pregnant, then what will we do? We will start her on low molecular weight heparin. In pregnancy, we will just continue the heparin. Okay, others we don't give in pregnancy. If the patient was on warfarin and now she wants to get pregnant, then switch her to low molecular weight heparin. Okay, and what should be the INR between B? It should be 2 to 3. Okay, then when the INR is between 2 to 3, For 2 consecutive days, we discontinue low molecular weight heparin and start the patient on warfarin. Now, if there was some underlying cause of the DVT, then we give the anticoagulants for 3 months. But if there is no cause, the patient is just having it, then we continue it for lifelong or up till 6 months. So mostly it is for lifelong. They are on heparin and warfarin. Okay. Pulmonary embolism, same. Anticoagulants, history of maybe a DVT or any other history. If pregnant, do ventilation perfusion scan and start the patient on DOAC. Diabetic emergency, what is it? Diabetic ketoacidosis or HSS. Treatment for both of them is the same. If the patient has diabetic ketoacidosis, what do we start them on first? We start them on normal saline. Okay, normal saline, potassium chloride, and insulin. This is the basic investigation they want you to know. Normal saline, potassium chloride, and insulin. Okay, the triad of hyperglycemia, ketosis, and acidosis due to severe insulin deficiency and counter-regulatory hormone excess. Precipitating factors are infection, cardiac or mesenteric ischemia, MI, intoxication, or insulin omission. What are the signs? Polyuria, polydipsia, malaise, noxuria, maybe some nausea, vomiting, abdominal pain, signs of dehydration, fatigue, stupor, coma. All of these are the signs and symptoms of DKA. Same. Then investigation, first of all, do the capillary blood glucose. Then after that, we will do CBC, electrolytes, calcium, magnesium, phosphate, ketone levels. Management, start the patient on normal saline. Okay. Along with normal saline, we have to check the patient's potassium level and start the patient on potassium chloride. Okay, if the levels are less than 5.5, they're giving you the levels of less than 5.5, start the patient on potassium chloride. And if along with that, start insulin. But if the potassium levels are less than 3.3, then we do not start on insulin. First, we will correct the potassium levels. After that, we will start the insulin. And once the blood glucose level is less than 14, then we will add dextrose along with normal saline. Similarly, for HHS, hyperosmolar glycemic state, same presentation, mostly in type 2 diabetic patients, and the blood glucose level will be very high. It will be 44 to 133.2. The presentation will be the same, the symptoms will be the same, and the treatment will be the same. Okay, both of them have the same treatment. Hypoglycemia, the patient will present with hypoglycemia. What is the treatment? If the patient is conscious, can take fluids, we will give them some oral glucose, we will give them fruit juices. If the patient is unconscious, cannot take anything orally, we will give them IM glucagon or IV glucose. Okay. Electrolyte disturbance. In electrolyte disturbance, the patient will, it can be hypernatremia, hypo. For both of them, we are giving normal saline. Okay. What are the symptoms of hypernatremia? They will give you the values. Okay. They will give you the normal value and they will also give you the abnormal value. So according to that value, you will assess, okay, if the potassium level is high, sodium level is high, sodium level is no, and then the treatment will be accordingly. So in hypernatremia, what are the most common causes? It is mostly in elderly, disabled patient. Maybe some patient is on diuretics, increased fluid loss from the body, or has diabetes insipidus. Symptoms: lethargy, weakness, irritability, edema, seizure, coma, with severe elevation of sodium levels. We have to restrict the salt, give normal saline. Okay, and within 24 hours, there should be no more than 12 millimole per liter in sodium because of the risk of cerebral edema. So what is the complication? They can be cerebral edema. So we have to not decrease the level more than 12 millimole in 24 hours. For hyponatremia, the patient will can have SIADH. The patient can have any adrenal insufficiency, hypothyroid. Maybe in the diet there's increased fluid intake, maybe he or she has congestive heart failure, increased fluid accumulation in the body. What we'll do, they will present with headache, seizures, decreased level of consciousness. If there's any hypovolemic cause, start the patient on normal saline. If there's any hypervolemic cause, then restrict the fluid and sodium and start loop diuretics if severe. Okay, hypervolemic, increase water in the body, then just restrict this fluid and give the patient loop diuretics. Hyperkalemia, it can be due to any rhabdomyolysis. Maybe the patient had some injury, crush injury, and because of that, the muscles were being, there was injury of the muscles, and due to that, there's hyperkalemia. Insulin deficiency, then metabolic acidosis, renal failure, any medications they are taking, all of these can be the cause of hyperkalemia. They present with nausea, palpitation, dysrhythmia. Start the patient first. If the patient has hyperkalemia, we have to protect the heart with calcium gluconate. Continuous monitoring of the with ECG. Start the patient on calcium gluconate, and now after that, start the patient on dextrose water plus insulin or salbutamol or sodium bicarbonate. For hypokalemia, same. It can be due to any diarrhea. It can be insulin. The patient is on insulin, diuretics, anorexia. Patient, they can have hypokalemia. Nausea, vomiting, fatigue, muscle cramps, constipation. Start them on potassium-sparing diuretics, okay, or Kader. And for this hyponatremia, the rise should not be more than 8 millimole in 24 hours. Because what it can cause demyelination. Okay. In hypo and hyperkalemia, we just have to do continuous monitoring with ECG. Then hyperkalemia, the patient has increased increased calcium levels, hyperparathyroidism, maybe there's some underlying malignancy, some medications the patient is taking. What is the treatment? Give the patient fluids, fluid. That is the treatment for hypercalcemia. Along with that, if not working, then bisphosphonates. After the fluids, then bisphosphonates. And the patient will present with a history of some abdominal pains, muscle pains, maybe some psychiatric abnormalities, bone pains, renal stones. All of these are the symptoms of hypercalcemia. Some constipation, hypocalcemia, hypoalbuminemia, liver dysfunction, primary hypoparathyroid. Okay, and what is the symptoms? Hyperreflexia, paresthesia, tetany, Chopstick sign, and Trousseau signs will be positive. We are giving calcium gluconate. Okay. Then for hypertensive emergencies, okay, whenever there's a hypertensive emergency, if there is even a pregnant lady like eclampsia, preeclampsia, the best medicine, the drug we are giving is labetalol. Okay, just remember labetalol we are giving. For hypertensive emergency, we start the patient on labetalol. What will we do? We will do the basic investigation, CBC, electrolytes, burn creatinine, urine analysis, and then manage accordingly. But depending upon the cause, there is a difference, but for the management, to decrease the blood pressure, we have to start the patient on labetalol. That is the best drug, okay? Generally, strategy is to gradually and progressively reduce BP in 24 to 48 hours. Okay. Initial therapy is labetalol and nitroprusside. In preeclampsia, stabilize the patient, all that we discussed, and surgical consultation, obstetrical consultation. If there is some other cause, like the patient has some aortic dissection, then a reduction in the BP. Along with that, the neurological surgical consultation. If there, in case of excessive catecholamines, what is that? When are the catecholamines increased? In pheochromocytoma. Okay, then we have to avoid beta blockers, except labetalol. Still, we are giving labetalol. Okay. So the first choice for hypertensive emergencies is labetalol. Okay. Acute coronary syndrome, I just discussed it in the chest pain. Then if the patient has sepsis, depending upon the type, the patient just start the patient on IV fluids, ABCs, take the blood culture, start on empiric antibiotics and treat accordingly. If there's some external source, like the patient has some Foley's catheter, any other other foreign body in the that is the source of the sepsis, just remove it. Okay. And what do you measure in sepsis? That is the lactate levels, serial lactate levels. And how do we manage it in the ED? Measure lactate level, remeasure if initial lactate is more than 2 millimole. So the person is presenting with signs of sepsis or septic shock, then what do we have to do? We have to start the patient, we have to measure the lactate levels. So if the lactate levels are more than 2 millimole, then we repeat them. Obtain the blood culture, start the patient on antibiotics and IV fluids. Okay. And remember, in sepsis, the temperature can be very high or even the temperature can be low. Okay. The patient can present with pyrexia, or patient can present with hypothermia also. Then in stroke, the patient will present elderly patient sitting, eating food, and all of a sudden they couldn't eat, they couldn't move their arm or leg. So what is this? This is stroke. But if it lasted for some time, while coming to the emergency department, everything became fine. The person can now speak, now can eat, can move his arms and legs. So it was TIA. Okay. If it persists, then it is stroke. This is the difference between the two. And what will we do? We have to do the CT scan, neurological consultations, CT scan. That is what we will do. Management in a stroke patient. If the patient has stroke after ABC, they want to know that you are putting the patient on NPO. Okay. In the ABC, after ABC, we have to do NPO. Give the patient NPO because there can be a risk of aspiration. So never give anything to the patient. Always keep the patient on NPO and then start the patient on thrombolysis. And what do? We give the patient dual antiplatelet therapy. Aspirin, clopidogrel, dual antiplatelet therapy for 21 days. Elevate head of the bed if a risk of increased intracranial pressure, aspiration, and worsening cardiopulmonary status, NPO and cardiac monitoring with or without. And after that, after NPO, ABCs, starting the patient on platelet, what we have to do? Neurological consultation. If the patient has had a TIA, then what we will do? We will start them on aspirin. Okay, if any contraindications, then start them on clopidogrel and statins. Then for any ENT otolaryngology, we did this dizziness, vertigo. If there is any pain, just do the otoscopic examination. Depending upon the presentation, treat it. Sudden hearing loss in elderly is most commonly due to this sensorineural hearing loss, and it can be a medical emergency. We have to give high dose steroids. Anything that is all of a sudden, this is acute sudden hearing loss, sudden vision loss, signs of cauda equina, all of these are emergencies. Okay, sudden blindness, what we have to do? Just start the patient on high dose steroids. Okay, and urgent referral to the required specialty. Epistaxis, patient is presenting with epistaxis. The most common cause of epistaxis is digital trauma. okay, just with your finger digging in, and that can be the cause. So what we will do, first, after doing the ABCs, we have to ask the patient to pinch the nose for 20 minutes, and they will do this twice. Okay, after doing this twice, if the bleeding has not stopped, what will we do? We will do the cross matching and type and prepare 2 units of blood. Along with that, we have to now proceed to the anterior nasal packing. For anterior nasal packing, either we will use anesthesia like lidocaine with epinephrine, apply it and pack the nose, or we can do this cautery with silver nitrate, and always cautery just one side. Okay, don't cautery both the sides because they can be perforation. This is our treatment. After pinching the nose twice for 20 minutes on the cartilaginous portion, then anterior nasal packing, silver nitrate, follow up in 48 to 72 hours to remove the packing. Okay. And if the patient has any underlying coagulopathy, always try to use coat the packing with Vaseline gauze. Okay. Because if you will remove the gauze, again bleeding can start. And after that, ENT consultation. If still the bleeding has not stopped, prepare the patient for posterior nasal packing by an ELT specialist. Consult him and they will do it. Vaginal bleeding, the same we discussed. And OBS, it's the same everything. Nephrolithiasis, the patient is presenting with pain in the flank area, radiating towards the groin, radiating towards the tip of the penis. Along with that, the patient may have some history of nausea, vomiting, high-grade fever. Remember, the pain of nephrolithiasis is very severe, very bad. The patient won't be able to tolerate it. They may have a history of some stones, or may have a family history of stones, might even not have any history, may have some history of intermittent urination, some problem with the stream. All of these can be present. What we have to do? We have to do after the investigations, if the patient is pregnant lady or their children, we are doing ultrasound. Okay, if they are other than that, the diagnostic investigation is CT scan. After CT scan, if we see them, then we have to move to KUB. So first investigation is CT scan, and after CT scan we do KUB. What is the management? NSAIDs, antiemetics, IV fluids. If the stone is less than 5 millimeter, just give increased fluids and the stone will pass out. If more than 5 millimeter, or the patient has signs of any obstruction, patient has sepsis, patient has single kidney, then what do we have to do? We have to consult the urologist. Okay, admit the patient, consult the urologist, and we will perform the not us, the urologist, they will perform the nephrolithotomy. Okay, lithotripsy. So even if they are telling you that the size of the patient is the stone is 3 millimeter, but the patient has high-grade fever, the patient has signs of obstruction, not able to void, or the patient has a single kidney, then what we have to do? We have to admit the patient. Okay. Then ophthalmological emergency, if the patient has anything, any foreign body goes in the eye, just wash it with copious irrigation with saline. Okay, do copious irrigation with saline, and then under SLE, remove it with a cotton swab, a sterile needle. And always, because now a foreign body is in the eye, what we have to do? We have to give tetanus prophylaxis and antibiotics. In acute angle closure glaucoma, the patient will present with sudden onset of unilateral pain. All of a sudden, the patient has nausea, vomiting. The pain is very intense, cannot see. There may be halos of light around everywhere. So what we have to do, we will give the patient timolol and ophthalmological consultation. Similarly, if there's any chemical burn, what we have to do, irrigate the eye with normal saline and do ophthalmological consultation. Orbital cellulitis, history of some infection, history of some sinusitis, history of some insect bite, and now a young child is presenting with swollen eyes, cannot move the eyes, pain with eye movement, headache, fever, high-grade fever, ophthalmology consultation, because there are chances of loss of vision. So immediately start the patient on IV antibiotics and do ophthalmology consultation. Retinal artery occlusion, sudden painless monocular vision loss, all of a sudden, and on fundoscopy, what will we do? We see cherry red spot and retinal pallor. On Google, write this and look at the fundoscopic picture, what it looks like. Okay, what we do, massage the globe, decrease intraocular pressure with topical beta blockers or IV mannitol. If retinal detachment, the patient will come with, all of a sudden, I felt that a curtain, something fell down. Okay, and now there are floaters of flashes of light, floaters. Patient cannot see. So what we'll do? Ophthalmological consultation. Then for dermatological emergencies, all of these, the treatment is almost the same. The Staphylococcus aureus kill syndrome, do take out the pictures and look at them, okay? What is it? It is caused by coagulase positive Staphylococcus aureus. Mostly it occurs in children, fever, irritability, malaise, skin tenderness, and there will be flaccid bullae, okay? That D-square made in large sheets. In Stevens-Johnson syndrome, toxic epidermal necrolysis. Both the presentation will be the same, maybe caused by some drugs, sulfaphenitoins, penicillin, usually occurs in adults. And what is the difference? The difference is the surface area of the body involved. If more than, if less than 10% body surface area is involved, it is Stevens-Johnson syndrome. If more than 30%, then it is TENS. In between, it will be both. Okay, and we will admit them in the ICU and treat them as a burn patient. Similarly, for toxic shock syndrome, history of any foreign body or a female coming to you with a history of tampon or any nasal bleeding and there was a packing. So these can be the causes. We have to remove the foreign body and treat the patient. IV fluids, antibiotics. Erythema multiforme, it is due to herpes simplex, viral, there will be a viral prodrome, history of any viral infection, 1 to 14 days before the rash. And these are big rashes in the body, okay? Circle-like rashes. All of these are derma, so you need to take out the pictures, just write on the Google and see the pictures, what they look like. Pyoderma gangrenosum, the patient will have a history of any rheumatoid, inflammatory bowel disease, leukemia, immunocompromised patient. They will present with painless macules, bulla, pustules, sloughing of the base, and gangrenous ulcer. And it will be gangrenous ulcer. They will have a history of IBD. And when on physical examination, you will just see that there's some ulcer in any part of the body, most probably in the lower extremities. Okay, and the patient didn't bother about it because it was painless. Then disseminated gonococcal infection, mostly a history of some sexually transmitted disease. Okay, highly multiple sexual partners might have fever, skin lesion, arthritis. And then septic arthritis, they will have a larger joint such as knees, ankles, and elbows. Skin lesion usually appear in extremities and resolve quickly. And in gonococcal arthritis, they will give you a history of migratory arthritis. One day the history was in, the pain was in left knee. Now the left knee is fine and it is in the right elbow or in the right knee. Then meningococcemia, same history of headache, flu-like symptom, nausea, vomiting, and they have a rash all over the body. Okay. After taking the history, physical examination, in all of these, mostly they will give you the pictures. Okay, this is the picture. What is the diagnosis or what is the treatment? This is what they're expecting from you. Management, start IV fluid, then electrolyte control, vasopressors if hypotensive, and if there's any infectious cause, then prevent it, or any foreign body, remove it. IV antibiotics you will start. If there's any medication that caused it, stop the medication and start the patient on antihistamines if any allergic or something like that is there. Environmental. Okay, now heat exhaustion, heat stroke, this is important. What is the time? Now in heat exhaustion, the patient will present with malaise, headache, fatigue, body temperature will be less than 40.5. Okay, in exhaustion, the temperature is less than 40.5. We will just ask the patient to rest in a cool environment, start on IV normal saline, and that's it. Okay, but in heat stroke and exertional heat stroke, classical and exertional, the temperature will be more than 40.5. Okay, in classical, it can be in elderly, sedentary lifestyle, maybe in the nursing home. They will have dry, hot skin, and may present with seizures, delirium, altered mental status. In the exertional, an athlete coming from some marathon, or someone doing exercises in the heated areas, all of them, they will present with increased sweating. Okay, so what is the treatment for both of them? It is cool body temperature with water mist, okay, ice immersion, and monitor body temperature closely, usually using rectal thermometer. Okay, how are we monitoring the body temperature? With a rectal thermometer. So in this, basically what we have to do, we have to cool the body back and put the patient in ice immersion, start them on IV fluids so that the temperature comes back. In hypothermia, the patient body temperature will be less than 35. An alcoholic or a homeless coming to the emergency department with some hypothermia, or somebody found a homeless patient out in the street, brought in the emergency department, what is the next step, or what is the cause? So it is mostly hypothermia. Okay, how will we treat them? We have to cover them with insulating blankets, warm the temperature body first with insulating blankets. There's a bear hug also, we call that, and we use that also. Along with that, what we have to do, start warm IV fluids. Okay, so external warming and internal, both of that we will go together. Insulating blankets, and along with that, we have to give the patient warm humidified oxygen and IV fluids. And we have to keep an eye on the after drop phenomena. Okay, what is after drop phenomena? That the patient can go in arrhythmias. Okay, warming of extremities causes vasodilation and movement of cool pooled blood from extremities to the core, resulting in drop in core temperature, leading to cardiac arrest. So to prevent this, we have to manage both of them together, external warming and internal rewarming. And always write warm fluids. Okay, even if you are writing peritoneal dialysis, write warm fluid, because that is the word they're looking for. Then in frostbite, the patient is presenting with frostbite. What do we have to do? Start the patient on oxygen. First thing we will do is give the patient morphine, okay? High dose opioids, analgesics, because it is very painful. Put the patient in normal temperature, immerse, or 42 degrees centigrade, okay? For 10 to 20 minutes to bring the temperature of the body back. And give him tetanus prophylaxis and penicillin G antibiotic. For burns, we should know the rule of 9. Okay. What is first degree burn? Epidermis is only involved. These are superficial burns and painful and tender to palpation. Then second degree, there are two types, superficial partial thickness and deep partial thickness. In superficial partial thickness, blister formation occurs and they are very painful. In deep partial thickness, skin will be blistered and the sensation will be absent. Full thickness is third degree with epidermis and all the dermal layers is involved. Skin is pale, charred or leathery. And fourth degree, fat, muscles, even the bones are involved. What is the management? Remove the noxious agent, stop the burning process, establish airway if needed, then resuscitate the patient with IV fluids, start IV fluids. And remember this Parkland formula. Okay, Ringer lactate 4 cc per kg per percentage of body surface area burn. What is the, you should know, like 4.5 is the posterior arm, 18% is the trunk, like this. Just know this, they will give you this percentage is burn. How much fluid do we have to give the patient according to his weight and everything. Inhalation injuries due to maybe the person was in some burn, the building started burning, or the patient had some smoke injury. What do we have to do? Just measure the carboxyhemoglobin level, ABGs, chest X-ray. If it is some burn injury, the carbon monoxide poisoning and cyanide poisoning, both of them are managed together. Okay, so carbon monoxide, start the patient on 100% oxygen, and for cyanide we will give hydroxycobalamin. Or it can also be like a carbon monoxide poisoning. The patient might have was found unconscious in the garage. Okay, so when they're saying that the patient is found unconscious in his or her garage, then it is most probably they were trying to commit suicide and it is carbon monoxide poisoning. Okay, the car was on, or in a patient living in a small house in the winter area is presenting with altered mental status or headaches. They're presenting with headache, nausea, vomiting. So maybe there's some leakage from somewhere and of the ventilation area. So we have to start them on 100% oxygen. And they can give you that the PO2 was normal, oxygen saturation is low. So what does it suggest? If they're saying the patient has a history of headache, nausea, vomiting, mild intermittent headaches, and the oxygen saturation is normal. Partial pressure of oxygen is normal, but the saturation is low. So it is most possibly carbon monoxide, and we have to give them oxygen. Bites, whether it is any animal bite, whether it is a human bite, we have to give them clean the wound, debride it, irrigate it, start them on antibiotic, that is amoxicillin plus clavulanic acid, and give them tetanus prophylaxis. Okay, that is the basic management of bite, all human bite or animal bite, any bite, that is. If there is any rabies, if the patient had a bite from a dog or any other animal that is rabid, then what do we do? We give them rabies vaccination also. Okay. If the animal has run away or the animal, we do not find the animal, then we will just give them the vaccination immunoglobulin. But if we find the animal is there, if it was a pet, then we keep the animal and monitor the animal for signs of rabies. Okay, but if it is a wild animal, then we do the euthanasia, cut the, and check his head and everything for the signs of rabies. So you should know whether if the animal runs away, what we have to do. If we have the animal, then what we have to do, and follow up and assess the patient for any signs. Insect bite or sting, same anaphylactic reaction. Toxicology, any person coming with toxicology, the basic treatment is this, don't. Okay, dextrose, oxygen, naloxone, and thiamine. Along with that, inform the poison information center, and we are starting the patient with activated charcoal. That's the basic. Everything, whatever the poison is, it is acetaminophen, it is any TCAs, any other poison. First treatment is activated charcoal. Okay, then after that they have given the antidotes for everything. So just remember the antidote for this is this. Okay, and that's it. That's the end of the emergency medicine.